Lara Nixon. I'm a family physician and associate professor with the Department of Family Medicine at the University of Calgary. And I'll start by acknowledging the land on which we are all coming from today across the province, and appreciate that we share the traditional and current lands of many First Nations, Métis, and Inuit people whose resilience and presence with us remind us of our treaty obligations and relationships. I'm very fortunate to hail from the Ukraine and Scotland in my family's background, and to have lived, worked, and played here on Treaty 7 lands. The province of Alberta includes territories in Treaties 4, 6, 7, 8, and 10, which include a diverse array of culturally distinct Indigenous peoples, whose histories, languages, and cultures continue to enhance our communities and remind us of our ongoing relationships with each other, the land, and our own processes of reconciliation. Next slide, please. Thank you. So just so everybody's aware, we do receive some in-kind support from the Alberta College of Family Physicians in the form of webinar infrastructure and staff supports, for which we're very grateful. I am part of the planning committee for this event, and we have very lively monthly discussions to help bring all of this together, and do so in a manner that is informed by PCN membership and prior participant feedback, and hope you find today and future presentations useful. Please do feel free to join us as well. If you have interest in becoming part of the planning committee, please let us know. We have some openings. And the rounds are intended for anyone, but designated or designed more for primary care teams. We meet 6 times a year and focus on chronic pain and issues common to people with pain. We rotate the weekday in an effort to make it more available to more folks, and have a standard time of 5:30 to 6:45 by way of Zoom. We'll ask you to provide feedback. Like I said, we are really keen to ground our sessions in community and audience needs. There'll be a link towards the end of the session, and you will also receive opportunity to provide feedback on the evaluation form shortly after the session. If you have technical or logistical questions, aren't hearing the audio or whatnot, please use the chat box. Otherwise, if you could please use the Q&A function to ask any questions related to the content of the talk, and that gives others opportunity to upvote. And sometimes the questions can be answered in the Q&A function. But yes, there'll be opportunity to potentially ask questions throughout this presentation, not just at the end. So please fire away. So just to give you a little heads up, today's session is followed by the next session in March on childhood trauma and the development of pain by Dr. Melanie Knoll. We have a session on nutrition and pain planned for May, and a pain and trauma related to migration session planned in July. So we have a poll ready to see who's in our audience today by discipline. If you could just click on which most suits you or fits your role. So it looks like lots of fellow family physicians, but a nice sampling from lots of colleagues, nursing, psychology, physio, pharmacist, NPs. That's great. We'd like to know where you're chiming in from today, if you could also let us know that. And there we go. We've got our, looks like, again, nice broad representation from across Alberta, as well as areas more to the south. Thanks so much. So our session today is to support our confidence in diagnosing fibromyalgia and explaining the implications of a diagnosis to a patient, outline evidence-based treatment approaches for fibromyalgia, and alert you to the clinical pathway and toolkits for primary care management of fibromyalgia. I'd like to introduce Dr. Laurie Montgomery, for those of you who have not had the pleasure of meeting her or working alongside or with her. She's a family physician with fellowship training in pain management, including headache, neuromuscular skeletal pain, pelvic pain, and palliative care. Her clinical work is in the Alberta Health Services Calgary Pain Program, where she sees patients together with a large multidisciplinary outpatient team. And she is the community integration medical lead with AHS Community, Rural, and Continuing Care. And she is a clinical associate professor in the departments of family medicine and anesthesiology, perioperative and pain management at the University of Calgary. Many hats that she wears. Hope you're welcome, Dr. Montgomery.
Thank you very much. I'm very excited to be here. So the first test of my skills is whether I can actually share my screen, which I'm hoping is about to happen. And Laura will tell me if I have managed to achieve that.
Sure have. Looks great, Laurie.
Awesome. Okay, carry on. Excellent. So I have somewhat slightly tongue-in-cheek titled this Mastering Fibromyalgia. I'm not actually promising that we're going to master fibromyalgia by the end of the hour. But I do think that, and I'm hoping that there's going to be lots here that will help you to feel more confident when you see people with fibromyalgia. And one of the reasons that has prompted us scheduling this talk is to talk about a new clinical pathway, which we are developing. I had hoped it would be finished by today. We're not entirely finished, but we're getting close. So I'm going to give you a bit of a teaser of the pathway so that you know what to expect when you see it. In terms of disclosures, I have no industry affiliations. I get some teaching honoraria from a bunch of different organizations. I have a small grant from the Hotchkiss Brain Institute, which is part of the university, for a pilot clinical trial that I'm not going to be talking about today. And I have a medical leadership role with AHS. So we talked about the learning objectives, and I'm very happy for you to ask any questions that come up too. I'm going to try and leave lots of time because I can't entirely predict what you need to know in order to feel confident diagnosing and treating fibromyalgia. So I'm trying to leave lots of space for you to ask some questions and have some discussion. So as I said, one of my priorities here was to introduce what will be the pathway coming soon, fibromyalgia. I'm going to take a break from the sharing of the screen for a moment and share the Specialist Link website for those of you who might not be familiar with it. So for those in Calgary zone, you're probably super familiar with it and use it all the time. If you're not, then this might be new to you. So specialistlink.ca. If you are in Calgary zone, you can use this to get telephone advice from a number of specialists. If you are anywhere in the known universe, you can use this to find some clinical pathways. So one of the newest pathways to come up, I think the most recent one to show up on the Specialist Link is the alcohol use disorder pathway. So just to give you an idea of what the pathways look like, they are a combination of family physicians and specialists with an interest in the area kind of get together and pull together the evidence that already exists. We're not creating new content here for the pathways. We're pulling together what's already out there and trying to put it in a useful form for people to use. So this is kind of what the average pathway sort of looks like. Anywhere that you see a little arrow like this, it's gonna, if you know how to screen for alcohol use disorder, you don't need to click on the arrow. But if you don't and you need a tip, then this will take you to some information about how to screen. So if you are looking for example, the headache pathway, you'll find that under neurology. And very soon you will find as I said, a fibromyalgia pathway. There also will be a generalized pain pathway coming up, and we also have in development a pathway for concussion and post-traumatic headache. So hopefully those will all be coming soon to a special link website near you. So what I'm going to give you today is a bit of a teaser of what will probably be showing up on the pathway. The pathway is very nearly done. Important for a bunch of reasons, and one that probably will be fairly obvious to everyone is that fibromyalgia is super common. And so how common it is depends on where you measure it. So if you measure it in a tertiary pain clinic, you're going to see it's, 40% or so of the patients that get referred in some cases. It seems the most recent data that we have from big population level studies seems to be somewhere between 3 and 8%, and it seems to be pretty prevalent around the world. One of the reasons why it's important to have the pathway and for us to talk about this is increasingly many of you will already have experienced that specialty services are declining referrals for fibromyalgia. So for a long time in Calgary zone, rheumatology has not seen referrals for fibromyalgia. Now as well, the Chronic Pain Center in Calgary, it is not one of our inclusion criteria for referral to CPC. So really important that we develop good skill sets in the medical home and also in the PCN clinics for managing this. So I mentioned the big population level studies. We have learned a lot in the last few years about fibromyalgia from those kind of big studies that look at big, broad populations. We had some assumptions about fibromyalgia that were probably based on the fact that most of those studies were done in tertiary centers. With a very selected population of people. So we used to say that fibromyalgia was sort of 7-to-1 more common in women. That is probably not true. It's still more common in women, like many chronic pain conditions. It's probably closer to 3-to-1 than it is 7-to-1. And we used to say that fibromyalgia is sort of this terrible doomsday diagnosis that there's nothing we can do about it, and it's just going to be relentlessly progressive and get worse until you, I don't know, disintegrate and fall apart. That's really not true. So when you do these big population level studies, it turns out there are many people who have symptoms for a while and then they don't have symptoms for a while. They fit criteria for months or years, and then they don't fit criteria anymore. So it is, and there are many things that we can do to help. So it's definitely not sort of this doomsday thing. We used to consider it a rheumatologic diagnosis, and we sent all of these people to rheumatology, so they developed some expertise in evaluating it. But the more we learn about it, we realize it's not a rheumatologic condition really at all. It's a nociplastic pain condition. So that is a very good reason why rheumatologists are not seeing fibromyalgia much anymore. So what is nociplastic pain? Some of you might be saying. So for those of you who aren't nerdy and immersed in the pain language of the International Association for the Study of Pain, we think now about, we used to talk about nociceptive pain, neuropathic pain, visceral pain. We now have this category of pain that we talk about, which is nociplastic pain, which comes from altered nociception. So we're talking about not tissue damage of a particular type, but we're talking about a dysfunction in the nervous system processing of pain. So it's a disorder of the central nervous system, really. So really, if we're thinking about a specialty where it belongs more than rheumatology, it's probably neurology, but good luck trying to get the neurologists to take responsibility for fibromyalgia. So this is a disorder of family medicine, which I've been saying to the residents for 15 years, and they all look at me like I have three heads because I'm actually quite excited about that. That this is one of those diseases that we can own in family medicine and do a really good job of managing. There will be patients that are going to need some extra help, but for the majority of people with fibromyalgia, the skill set is there in primary care to manage these patients. One thing that I want to say when we're talking about nociplastic pain, so it's a disorder of pain processing. That doesn't mean there is no tissue damage. So in some of these patients, there will also be some pain generator that is some cause that is related to tissue damage. But the core problem when we're talking about fibromyalgia is about pain processing. So nociplastic pain, we talk about as being more of a malfunction in the alarm system than it is the structures. So, you know, if a fire alarm goes off in the building where you are right now, you're all going to evacuate and you're going to wait for the fire department and they're going to look around and see if there's a fire. And if there is not a fire, they will conclude that there's a problem with the alarm system. And that's essentially what's going on with nociplastic pain. One of the other ways that we talk about it is we talk about the fact that your pain system has an accelerator and a brake pedal. It has some excitatory elements to the nervous system and it has some inhibitory elements. So for most people, those are in balance. Your nervous system is constantly deciding, does this signal need to be boosted because it's important, or do I need to inhibit that signal because it's not really important? And in nociplastic pain conditions, of which fibromyalgia is kind of the classic example, the accelerator is very active and the brake pedal is not as active as we would like it to be. So that's nociplastic pain. So in contrast to some of the ways that we have historically thought about fibromyalgia, it's not a musculoskeletal disorder. It doesn't mean you can't also have musculoskeletal issues, either in addition or because of the deconditioning that happens with fibromyalgia. It's not a psychiatric disorder. It's not a manifestation of depression or anxiety, although those do often co-occur. It's not just that people have poor coping. Poor coping is going to make the symptoms and the disability worse, but it's not just that somebody doesn't cope well and therefore they've got pain all over and a bunch of other problems. It's also not just physical deconditioning. It's not that you get deconditioned and then you develop all the things that look like fibromyalgia. Deconditioning is typically something happens because you're not moving around, because you've got pain all over. One of the things that I still hear all the time is fibromyalgia is a diagnosis of exclusion, and it's really not. So that means a couple of things. Fibromyalgia has a classic picture. It has a way that it very often presents, typically. There are some criteria that we look at to decide if this is more or less likely to be fibromyalgia. You don't need to rule out everything in the entire world in order to conclude that this is fibromyalgia. There's a few things that mimic it that we'll talk about that you need to keep on your differential. Most of those things you can rule out with a good history and physical. It doesn't mean you need to do every lab test that Alberta Precision Labs offers in order to make a diagnosis of fibromyalgia. And it also doesn't mean that any pain that you can't figure out is fibromyalgia if you can't figure it out, which is sometimes the way you see it applied. If I can't come up with a cause, then it must be fibromyalgia. And it's a little bit different than that. So there are some criteria which you may or may not use the actual questionnaire, but whether you use these questionnaires with patients or not, these have to be sort of in the back of your brain when you're talking to a person that you think might have fibromyalgia. So one piece of making the diagnosis is, do they have widespread pain? So this is the widespread pain index, sort of guides the patient, if you're going to give this to the patient, guides them through a bit of a check of where their pain is or has been. So important to remember that pain moves around for people with fibromyalgia. They don't have the same pain in the same places all the time. So the question isn't where do you have pain right now? It's where have you had pain for 3 months or longer? And tick all the boxes. And you want to see that there are some spots, upper and lower, left and right, that it's fairly diffuse. The more diffuse it is, the more likely it is to be fibromyalgia as the diagnosis. Somebody who has left shoulder pain that you can't figure out probably does not have fibromyalgia. And then the other side of diagnosis is thinking about all of the things that travel with fibromyalgia in terms of associated symptoms. So, and again, the more of them you have, the more likely it is that this is fibromyalgia. So the classic ones that we think about are fatigue, cognitive issues. People talk about fibrofog, and non-restorative sleep or sleep disorders. So those can help to steer you in the direction of, this is, if those things are present, keep going down the road. This is potentially fibromyalgia. People who have abdominal pain, and classically it would be IBS that travels along with fibromyalgia. People with a history of depression, people with headache, particularly migraine. So you can see all of the other sort of nociplastic conditions that are about pain processing all kind of travel together. So migraine. The other things that you'll very often see, and if you have lots of patients with fibromyalgia, you'll be used to a problem list that looks like this. TMJ dysfunction, painful bladder syndrome, irritable bowel syndrome. And they often tend to be very, very sensitive to all kinds of stimuli. So wind, cold, loud noises, flare my pain. And there is a subset of people with fibromyalgia who are super sensitive to medication side effects. So, if you think about your nervous system processing signals in a way that's not helpful to you functionally, all of those things kind of fall into that category of a nervous system that's irritable and not really, not giving you necessarily an accurate picture of what's going on around you. So there are some people have come up with some cutoffs here. The widespread pain index more than 6 and symptom severity scale more than 4. If the pain is not quite as diffuse, you want to have a lot more of those associated symptoms in order to think that this is fibromyalgia. But important to realize, symptoms vary for people from day to day. So, and they're going to report their symptoms as being less intense on a day when they're feeling really good. And also, when they originally developed these criteria, the widespread pain index and the symptom severity scale, they actually specifically said in the beginning there wasn't really a cutoff. It was just that the higher the score, the more likely it is that fibromyalgia is what you're dealing with here. And think about that as being an important consideration when you're planning treatment. So the list is not exhaustive of things that you need to think about for people that you think might have fibromyalgia. Lots of the inflammatory conditions, a good history and physical will rule those out. You don't need to do a ton of lab work. Hypermobility, benign hypermobility really classically will cause a widespread pain picture. They're not necessarily going to have all those other associated symptoms, though. They're just going to have the widespread pain. Things like MS, neuropathies, myopathies, you should be seeing some problems in physical exam and history that would lead you to think that there's some more focal neurologic issues going on. Sleep apnea worth screening for, because certainly, especially if you're seeing sort of a milder picture, that could be something that's driving the symptoms that you're seeing. Hypothyroidism is one of those classic ones that we want to rule out, because it can mimic all kinds of things, including fibromyalgia. That doesn't mean you need to do a TSH every 6 months for the rest of this patient's life. If the patient's had stable symptoms for quite a while and you measure it once, you're going to get a good sense of whether that's a contributor. As I said, depression is not, fibromyalgia is not just a manifestation of depression, but people can have pain symptoms and somatic concerns that are around a really severe depression. So keep that on your radar. Post-viral symptoms this is a really interesting one, because for many years we've seen a fibromyalgia picture that evolves after people have infections, particularly viral infections. So it's been really common for me to see people in the past who see their symptoms coming on after an EBV infection or something like that. COVID has been super interesting because the picture is exactly what I remember seeing from all of these other viral infections. But there's so many people with infection that we have a much larger population of people who are developing those kind of symptoms. So I hope that that means there's going to be an explosion of research to sort of sort out for us the connections and how this happens. MECFS is another one where you have to sort of entertain that as part of the picture. Typically, fatigue is going to be more of the disabling factor than the pain. So when you talk to somebody with chronic fatigue, I just get to the point where I just drop. I simply cannot move anymore. I have to lay down on the floor because I cannot do anything. And rest doesn't really help. Is more of the picture, and it's less of the migratory pain being the disabling thing and fatigue being sort of in the background of every day all the time. And then there are some drug side effects that can cause widespread pain. So you want to make sure that that's on your differential as well. Again, you're probably not going to see all those other associated symptoms like the IBS and the TMJ and the migraine and all of that are drug side effects. So a lot of this you can rule out with your history and your physical. There's a few lab tests you want to do. It's again not exhaustive, and many of these you will they will have already been done, and you can go back and refer to that, and they'll be guided by symptoms and history. If there are some comorbidities that are confusing, you certainly may want to ask for advice when it comes to diagnosis. Or if there are things where you're thinking, okay, there are some weird peripheral neurologic findings here, I think maybe this patient needs nerve conduction studies just to rule out a peripheral neuropathy or something. So those are going to be times when you're going to need to refer. Where can you refer? So if you are in Calgary zone, Specialist Link has a number of services that can give you some advice on how to whittle down the diagnosis or sort through some of the complex comorbidities. If you're anywhere in Alberta, you can use e-advice via Netcare, and so chronic pain is on there, one of your options. So we can talk through the diagnostic difficulties that you're having. So maybe before I launch into talking about treatment, I'll just stop there and see if there are any questions about diagnosis, or Jan, if there's anything lurking in the Q&A that we need to.
Yeah, no, there are no questions. Everything is crystal clear, so you can go on.
Okay. Very good. All right. So when we're talking about treatment, education is a treatment intervention, and that's really, really important for any pain condition. Really important concept is that education about pain is a treatment intervention. So education about pain can reduce pain levels and improve function. So it's treatment. We want to talk about pain neuroscience education early with virtually any condition, but particularly with fibromyalgia, where people are getting all kinds of mixed messages, and what they get on the internet is soup to nuts in terms of reliability. So we want to steer them in the direction of some things that are credible information. So when I talk about pain neuroscience, what do I mean by that? One is this discussion about the fact that fibromyalgia is a problem of pain processing. And so you have out in the periphery, you have these nociceptors that are sensing stuff going on. Sometimes that's things that would be painful for other people. Sometimes it's not. It's an alarm signal that perhaps in many people, my software is trying to update. Go away. Okay, hopefully that will go away. So in many people, that nociceptive signal will go to the spinal cord, the dorsal horn, which is kind of like a little mini brain doing lots of processing, is going to decide that's not really important. That doesn't need to be pain. Let's turn that off, turn the volume down on that. If it decides, okay, I'm not really sure whether we need to pay attention to that, then we're going to boost that up to the brain level. And there's going to be all kinds of processing that goes on there to decide, is this important or not? And then a signal that's going to come down that's an inhibitory signal if it's not important. So let me just, okay, this is annoying me. I need to make this go away. Okay. So if the brain decides that it is important, it's going to send down a boost the volume on that signal message, and you're going to pay more attention to that pain signal. Again, I always, when I'm talking to people who have fibromyalgia, I'm always using these metaphors of talking about the alarm system and the accelerator and the brake pedal, and how we're going to try and modify that as part of their pain treatment. So there has been research looking at what are the important pieces of pain neuroscience education that help people to get better. So people who get better in a pain program, what do they say about what was useful to them in terms of education? And one message that patients have picked out is the message that pain is protective. So your nervous system's job is constantly to be scanning the environment around you, trying to decide if you're safe or in danger. If the evidence that it sees around you for danger outweighs the evidence for safety, then it's going to give you a pain signal, which is a protective signal that you need to do something different because you're surrounded by threat. So that is true of any kind of pain, whether you have fibromyalgia or you break your leg or you stub your toe on the side of the table, your pain system is always trying to decide how important that signal is before it sends you a signal. The second piece of information that ties to that is persistent pain is overprotective. So your nervous system creates a bit of a buffer between where you have pain and where you're actually going to experience injury. And it gives you more pain when it decides that it needs to protect more. If it's giving you pain all the time that is getting in the way of your function, it's because your pain system is being overprotective. So I love this graphic that Dr. Wong developed to use at Calgary Foothills. So I'm now going to use it in basically all my presentations. So I love this little brain that is just hyper reactive and super, on guard, ready to defend you against this thing that probably does not need this much of an armed response because your system is being overprotective. So I use this graphic when I talk to patients a lot, and this is about the fact that if you look at the mountain on the left there, you have a level where you're going to experience pain, whether that's activity or movement, something you're doing that you're going to experience pain. Unless you blast right through that and go straight to injury, it's going to give you that signal a little bit before you have some kind of tissue injury. So I can bend my thumb back like this. Eventually, that's going to cause me pain. Not because I've sprained my thumb, but because my body is saying, you should maybe stop there before you hurt yourself. If you shift over on the right, when you have somebody who has fibromyalgia, they now have this huge buffer between the protect by pain level and the tissue tolerance. So now I can't open a door, I can't open a jar because my protect by pain level is way up here instead of down here. And so a system that's overprotective can be trained to be less protective. And that's a really important message. The third one, the many things impact pain, so many things can help, seems like a sort of bland motherhood statement, but it's actually, if you think about it, kind of revolutionary compared to what we used to say about fibromyalgia 15 years ago. So we used to just say, there's nothing I can do about this. You're going to have to learn to just cope with this pain. And what we know now is that there are plenty of things that we can do to help you reduce your pain level. So they just might not be gabapentin. And, historically, because our gabapentin wasn't helping, we sort of arrogantly went, oh, nothing helps. No, that's not true. There actually are all kinds of things that will help. So the evidence-based treatment plan of the things that can help, spoiler, none of these things by themselves are probably going to completely solve the problem. We need to be doing a number of things at once. So there has been all kinds of attempts to sort of come up with systematic reviews and sort of the Coles notes to the treatment plan for fibromyalgia. This is a relatively recent one. And it sort of highlights some of the gaps in the literature more than anything else. This group sort of looked at studies that looked at short-term outcomes, medium-term outcomes, and long-term outcomes. There was only one study that followed people for more than a year, which is a little bit problematic. The other, for me, bigger problem with most of these studies is that only 15% of them used some kind of specific criteria to diagnose fibromyalgia. So they were doing RCTs for fibromyalgia without really being entirely certain that the population they were testing had fibromyalgia. I'm going to talk more about CBT later because there were lots of problems with the studies that they found of CBT in this study, but I'm going to go into that in a bit more detail. Cole's notes was that all of the things that where they found an effect, it had a relatively small magnitude of effect. When they separated them out into the high quality studies versus the moderate and low quality studies, the high quality studies in terms of the interventions that had the best evidence of efficacy, they saw antidepressants, sodium oxybate, and CBT. And the moderate quality studies, all kinds of other things, virtually everything else that they looked at. So, little sidebar, most of you are thinking, sodium oxybate? I never use that to treat fibromyalgia. No, you don't, and there's a reason. The reason why they found a lot of high quality evidence in this systematic review for sodium oxybate is that there was one pharmaceutical company that got super excited about this and did a lot of really well done studies to try to demonstrate that it was effective in treating the symptoms of fibromyalgia. The problem is a lot of those studies didn't measure harm particularly well. And most regulatory bodies and guidelines and groups on balance have said the risk of using sodium oxybate for fibromyalgia outweighs the benefit. So it's still a small magnitude of benefit, although it was reliable in well-done studies. But the harms associated with it are probably not worth it, and it's super expensive. So it's not on formulary in any place that I could find. In terms of looking at the other options for treatment, if you sort of look at the plot on the right side there, you can see that most of those things are on the right side of zero, showing that the intervention is helpful. EEG neurofeedback and analgesics are not. And nutrition, that's a workshop for it. It was not as much data, and that is actually literally a workshop for another day. We are literally doing another PCN Pain Rounds on this topic. So again, put a pin in that for later. But virtually everything else that they looked at had some benefit. And that was in terms of short-term benefit. In the terms of the medium-term benefit, again, lots of these things showing that it's on the right side of the line, that it favors the intervention with a relatively small magnitude of effect. None of them is going to totally solve the problem by itself. The Coles notes to this, and what I believe is going to show up in the pathway when it shows up, is that the things that we have probably the best evidence for in terms of the balance of risk and benefit are SNRIs, gabapentinoids, and TCAs. There are some other things that you'll see used for fibromyalgia. Low-dose naltrexone has some decent data in very small studies that are never going to be larger than that. Muscle relaxants you might use for 14 days, a week after you shovel snow and have a flare or something like that. There's a little bit of evidence for nabilone that it improves sleep for people in fibromyalgia, not necessarily pain. Those things are probably not going to be in the pathway because there is a little bit less evidence backing them up. One of the things that is pretty clearly demonstrated is that we should be avoiding opioids in somebody with fibromyalgia for lots of reasons, but there's pretty decent evidence that it actually will make pain worse in many people. CBT, I said I was going to talk again about CBT. CBT has been very well studied in all kinds of pain conditions, more than 40 RCTs in fibromyalgia that show that it has been effective. So now the studies are not so much asking, does CBT work or not? The question is, in which patients, what kind of CBT, different, sorry, different waves and evolutions of CBT. So this study, for example, that I've cited here, compared traditional CBT with exposure-based, which is kind of deliberate exposure to things that cause pain. So sorry. And they also looked at internet-delivered CBT, which they showed was quite effective. Okay, I need to mute for a moment. So sorry. Okay. So CBT, definitely worth doing. Exercise is also a really important part of a treatment plan for somebody with fibromyalgia for probably half a dozen reasons. We could probably have an entire session on why exercise is helpful for fibromyalgia. Basically, every systematic review that looks at it is positive. They have tried to look at, is one particular kind of exercise better than another? And there isn't really any evidence that any one type is better than another. They've looked at aerobic exercise and strengthening and mobility. They all seem to have an effect on function and reducing pain levels. It looks like something that the patient will do. So adherence to the program is the most important thing, something that is interesting and fun and rewarding. Something that they can do regularly at a low intensity is probably best. And the idea is for any kind of pain, but sort of classically for fibromyalgia, if you are constantly pushing through pain levels to try to do more, and the classic pattern is you have a good day, so you decide you're going to go for a 5K run, and then you crash and you can't do anything for a week. That doesn't help you to retrain your nervous system to process pain in a different way. If you can practice low intensity activity that lives kind of right below that protect by pain level from that Twin Peaks model, if you can work at that level pretty consistently, teach your nervous system that this is safe, it doesn't need to overprotect, then it will give you a little bit more space and you can do a little bit more activity. So really important part of a treatment plan, and probably that's why any of these different kinds of activity, if it's something you didn't do yesterday or more than you did yesterday, it'll probably get you in the direction of retraining the nervous system and bringing pain levels down. So where do I access help with this, you might be asking? So 5 of the PCNs in the Calgary zone have multidisciplinary teams that have a very excellent background and training on helping you with the CBT component and also the exercise component. So that is really useful. If you are in one of those PCNs, I highly encourage you to make use of the team. In other places, or if you don't have those kind of PCN resources available to you, there's a couple of options. One that exists right now in the red circle is the rehabilitation advice line. So anywhere in Alberta, your patient can call this number and get some information on how to get exercise guidance. So they will do a little bit of assessment. It's physiotherapists and occupational therapists that answer the phone, do a little bit of an assessment, figure out what the patient needs, figure out where they are geographically, and try and match them up with resources that are useful for them. And in cases where they really need to do some kind of intervention and there really isn't a resource local to the patient, the providers there can actually do a little bit of Zoom guidance for the patient in terms of activity. And then coming soon, hopefully soon, one of the other boxes on this line will be the Alberta Virtual Chronic Pain Program, which will be an option for connecting people anywhere in the province with a virtual multidisciplinary team that can go through some of these concepts around pain education, CBT, and how activity reprograms your nervous system. In terms of referral, there is one place that I'm aware of in Calgary Zone, and that is the FibroFocus program that is run by Dr. John Pereira. And so if you go to that website, which is fibrofocus.com, right, John? Not .ca. You could put that in the chat. Pretty sure it's .com. Then you'll find some more information about the program, and the referral form link there has some information on how you would get your patient into the program if they're interested in participating. I love this website. We give it to everybody who comes to the Chronic Pain Center, and I'm pretty sure all of the PCN multidisciplinary teams are using this website. So this is Lorimer Mosley's patient-facing site where he talks about those concepts of danger and safety and how that affects pain levels. This little 5-minute animation is just a little bit of an introduction to the concept, and then there's a bunch more information on his website. I love this website, Power Over Pain. I used to give people all of these websites, Live Plan B Plus, My Sleep Well, and the Gentle Movement at Home. Now I just give them Power Over Pain and they can find all of those things there. Live Plan B Plus is a CBT online, self-guided, asynchronous CBT program for pain. My Sleep Well is tons of information, including CBT for insomnia. And then the Gentle Movement at Home is put together by Pain BC, and it's yoga and Tai Chi and Qigong and a whole bunch of different options for people to try out activity specifically when you hurt from head to toe. And it's I find it resonates with patients more than just saying, you know, go try this, but go slowly with it. When they do this and they have a provider teaching it who actually is assuming that all of you in this class are experiencing pain. So I find that really helpful. I have left a decent amount of time for questions. So Jan, what do we have in the hopper?
Yeah, we do. We have 2 questions actually there. One is well, that goes back to differential diagnostics. So what is the differentiation from somatization disorders?
Somatization disorders. Okay. Wow, we should add that to our list for next year because that is also potentially a whole other workshop. So there's a lot of disagreement in the literature about what somatization disorders actually are. The number of, so a lot of what historically was termed somatization disorders these days might fall under an umbrella of what are called functional neurologic disorders as well. It is much less common for purely emotional psychiatric issues to cause these widespread symptoms. It's not impossible, of course, but there are a lot of people, I think, who would frame that as somebody who's extremely anxious, has a very hyperactive nervous system, and in a sense, on a pragmatic level, why would you not treat that as fibromyalgia and talk about it that way? Particularly, you know, if you've tried having a conversation with a patient about somatization disorders, it often doesn't go very well when you say, this is all just because you're anxious, just be less anxious. It doesn't resonate very much, but, and I find with somatization disorders, with functional neurologic disorder, with fibromyalgia, that discussion of danger and safety and the hypervigilance of the nervous system seems to connect better, land better, and make more sense to people. And you can certainly have an impact on the mood component of the symptoms by doing all the same things that you would do for fibromyalgia. There's a huge overlap between pain and PTSD. And there's some evidence that if you just treat pain with CBT and graded exercise increases, you actually improve PTSD symptoms. So, so if it lands to talk to the patients about a hypervigilant nervous system, and our treatment approach is going to be exactly the same, arguably, you go with what resonates with the patient, I think.
Okay, thank you. To be fair to Naomi, Christina was first. So she has even described some of her cases. So her question is, what is the number one diagnosis you have seen labeled as a fibromyalgia, but in fact is not a fibromyalgia? And she added her case there. So Christina, would you like to unmute yourself and perhaps describe it for Lori?
Sure. So yeah, it was actually, I said to my patient, Lori, you came a week too early. Dr. Montgomery is going to be telling me exactly how to properly assess you next week. So she actually is wonderful. She's agreed to come back next week and see me after having done this course. So she describes this kind of widespread pain. She listed off about 5 different places where she's having this 8 out of 10 pain. Advil and Tylenol doesn't really do very much. She's sleeping poorly. She works in daycare, so probably her biggest complaint is she can't get up off the floor when she's down on the floor playing with the kids as easily. But it only lasts for about 2 to 3 months. I'm seeing her at about week 10 of a usual 12-week flare, and she said this has been going on for a few years, but she just hadn't told me about it yet. And so I was like, well, other than the fact that you seem to have these time periods where you're fine, I would think this is fibromyalgia. And like examining her, she's like tender all over the place. She's got that brain fog. So is it possible for her to have fibromyalgia and have these fairly decent periods of great function where she's not in so much pain?
Yeah, that's the super fascinating thing about these big epidemiologic studies, is that actually that's not an uncommon pattern for people with fibromyalgia. And, you know, so some of that might be other stuff that's going on around her that has triggered a flare. You know, the more of those associated symptoms there are. So, I mean, for somebody who's got relatively severe pain, the fatigue and the brain fog, for me, that doesn't distinguish very well in my population, because somebody who's got severe pain is going to be, you know, very focused on that and not focused on where they left their keys. And also it's draining, it's tiring, and they're often not sleeping well because of it. So for me, I tend to go for the things like the TMJ dysfunction, the migraine, the painful bladder, the IBS. The more of those that are there, the more likely I am to say this is probably fibromyalgia. If there's really none of those things, when you're asking about the thing that I see most commonly labeled fibromyalgia that isn't, I would say it's benign hypermobility. So I would like do the bait and score and see, I am hypermobile, by the way, but you know, can they do this? Can they bend over and put their palms on the floor? Do they hyperextend at the knees and the elbows? You know, those kinds of things very commonly presents as a widespread pain that, again, you know, might be really biomechanical related to activities that she's doing. If she's getting up and off the floor a lot, that might trigger a flare that's going to last for a while. Or if, you know, it happens in the summer when she's doing tons of activity, or it happens in September when school starts, then it might be much more biomechanical.
Okay, so hopefully that explains the case. Now I see Naomi's hand up. There is no comments from her in questions and answers. So perhaps Naomi, if you can unmute yourself and ask directly.
Hi, thank you so much. I was wondering if is a relationship between the pain overprotection in fibromyalgia and the kind of sensory processing hypersensitivity you can see in people with neurodivergence.
Oh, that's a really good question. I have been trying to do a little bit of research on that myself. So it's not something that shows up in the literature too much, the overlap, but it definitely, they use a lot of the same descriptors. There's this, and it's not all people with fibromyalgia, but there is this subset of people with fibromyalgia who are super, super sensitive to those things, textures and wind and temperature change and colors. And so it is definitely a subset that I see. I actually saw a patient today and I told her, I think 10 years from now, we're going to have a different word or a different classification for that group of people who have the fibromyalgia symptoms and fit all the criteria and have this subset of people kind of at the top of the pyramid who have that super sensitivity to environmental stimuli and things like that. They do, to me, they match up a lot in terms of their descriptors, but I was not able to find too much in the literature that addresses that.
Thank you.
Yeah, thank you, Naomi, for the question. I have two questions from Christine Gibson, one regarding exercise, the other one about the Sarno method / pain reprocessing therapy. So, Christine, would like to unmute yourself and ask?
Sure. Hey, Laurie.
Hey, Chrissy.
So my first question was about post-exertional malaise. We're seeing this a lot with long COVID. There seems to be some tie-in with fibromyalgia, and there's a lot of pushback from patients around exercising in the case of post-exertional malaise because their perception is it's a very big setback for them.
Yeah.
So that was question number one.
Yeah, well, and you know, when it gets to that sort of like, anytime I do anything, I just collapse and I can't move. That's where I think more in that ME/CFS category than fibromyalgia. But that said, with people who are super disabled, and I'm starting to see more people with long COVID, my approach is more when we're talking about exercise, we're really talking about starting where the patient is at. Like, what for you can you do even on a bad day? And for some people, that's like, I can get up and walk to the kitchen. Okay, so if that's what you can do even on a bad day, then getting up and walking to the kitchen is what we're starting with in terms of activity. And I find like providers sometimes have a hard time wrapping their head around the fact that the patient's baseline really might be that. And so they're asking them, well, I'm sure you can just walk around the block. And maybe they really genuinely can't. So making sure that you're actually starting where the patient is at and not several steps past that, I think is part of it. We had a patient a few years ago where we literally were starting with movement in bed. Like, you're lying down in the bed, can you bend your knee? Okay, you can do that with no problem. Okay, we're going to do that like 20 times a day and manage to actually get her up and around. It's not, back to work or anything miraculous, but, functional, doing ADLs. Because sometimes I think that pushback is because you're trying to start too far. But they're also, if it really is more in that picture of ME/CFS, it seems like that graded exercise activity approach needs to be a little bit different.
Yeah, the other question was about Sarno's method or / pain reprocessing therapy.
Oh yeah,
if you
you
can have some
pain
comments on
reprocessing?
that.
Yeah, Christine, do you do the pain reprocessing therapy?
Yeah, I studied it a couple years back with Howard Schubiner, and for those that it works with, it works extraordinarily well. And I honestly think it's just what you were saying, because I do trauma therapy. So it is that subset of people where it's kind of like a traumatic response that's stuck in the tissues, warning them of danger. And pain reprocessing therapy is such a good fit for that. But I just wondered what your experience has been.
Yeah, I mean, there's huge overlap in these approaches. Like, when I started reading the papers on pain reprocessing therapy, I was just thinking, well, that's a different way of framing what we're doing when it comes to talking about danger and safety and you know, approaches to activity. It's the same science that it's built on, but it is a different way of phrasing it and a different way of presenting it, and sometimes that lands better for a patient. I'm constantly fascinated, and I love the whole concept of learning and how the brain learns, and just the fact that we have to have 20 different ways of saying something to a patient, because we can be saying the same thing, but if it just use the wrong language, or it's just framed in a way that doesn't make sense, it's not going to be therapeutic. And I've been doing lots of reading lately about PTSD treatment and pain. And that's one of the really interesting things, that some people with PTSD really want to go for the trauma. They want to dig in, do the trauma work, and they feel like that's really important. It's hard work, but they really want to do it. A lot of people, when you try to send them for that, no-show constantly or drop those treatment programs because they actually don't want to go there. And there's some pretty good evidence that if you do the pain CBT and approach the fear avoidance and the over attribution of danger from the pain perspective, you're just skirting the issue enough that the patient will look at those and go, yeah, okay, that I can look at, that I can deal with. And you actually can significantly improve the PTSD symptoms without actually directly confronting that, because you're getting at the catastrophizing and the pain avoidance and all those kind of things from a completely different direction. So pain reprocessing therapy, awesome. Should all be certified to do that too.
Yeah, I can speak to that as well, because I took the online training too. So yeah, it's definitely interesting approach. Next question from Lorraine. Please comment on the use of cannabis for fibromyalgia. Some patients are definitely turning to this treatment.
Yes. So Health Canada collects some data. It's obviously not like 100% accurate, but they collect some data on who uses cannabis for medical purposes across the country and what they use it for. And for a long time, the most common reasons why people use cannabis medically are low back pain, migraine, and fibromyalgia, all conditions where it has not actually been studied. So when it comes to pain, our RCTs are in neuropathic pain. There's a couple of very small studies in fibromyalgia patients, but they're experimental type studies. Like one took people over a span of 12 hours in the lab and exposed them to different combinations of THC and CBD. So there are things like that. So the data is absolutely not there. That said, it is one of the most common reasons why people use it. So I always advocate that we should all be really good at talking to patients about how to use cannabis, what the, risk mitigation strategies are for using cannabis, what are the safest ways to use it, how do you try it out so that you minimize the harm, and be really systematic and scientific. I love, one of our psychologists at the Pain Center always says, encourage the patient to do an N of 1 trial and be super rigorous about the experiment that you're doing in you. Collect data, try the thing, collect more data, decide whether or not it's helpful for you.
Okay, thank you. And the very last question is from Diane. How useful is the pain scale? Diane, would like to comment on your question a little bit more? Oh, perhaps not.
No, that's pretty straightforward. Thank you.
Oh, Diane, that's Diane CU. Diane, I could talk to you about this all day. So you're talking about the numeric rating scale. Is that when you say pain scale? I'm assuming that's what you mean.
Correct.
Yeah, so the numeric rating scale is absolutely not useful if you think it's the equivalent of putting an electrode in somebody's brain and telling how much pain they're having. So it's not that, right? It's a subjective tool. It's a way of the patient communicating to you how much distress they're in. So when a patient says to you that they've got 15 out of 10 pain, it's not because they don't understand numbers and they don't know that 15 is more than 10. It's because that what they're telling you when they tell you 15 out of 10 is, I'm not sure I trust you to take me seriously. I'm not sure that you're going to help me. I'm not sure that you understand how distressed that I am. So it's a communication tool. And so I always tell people, I don't use a numeric rating scale to compare you to anybody else. I'm using it to compare you today to you in 3 months when I see you again. And it's just a shorthand for us having that conversation. So when we ask on our questionnaire, what's your minimum pain? What's your average pain? What's your maximum pain? I go through with them and say, okay, you said here your minimum pain was 3 out of 10. What does a 3 out of 10 look like for you? Oh, I'm going to work. I'm doing my thing. I've got pain. It's bugging me, but it's not really interrupting what I do. Okay. You said your average pain is 7 out of 10. What does a 7 out of 10 look like for you? Okay, 7 out of 10, maybe I'm going home from work early. I might take my opioid medication on a day when my pain is a 7 out of 10. Okay, you've said your maximum pain is a 10 out of 10. What does 10 out of 10 look like? Oh, I'm still going to work. I probably will take my medication a couple of times during the day, and that for me is a 10. I'm not going to try and talk them into that not being a 10. If that's your 10, that's your 10. That's just, now I have a shorthand. Now when they show up and they say their pain is 6 out of 10, I know where to put that. I know what that means for you. And then it's just a shorthand for us to communicate.
Perfect. Yeah. Thank you for the answer. No more questions. Seems like when we are at the end of our rounds today. Any last words?
Hi, Jan. There was actually just one question that was in the chat. I just private messaged it from to you. It was from Bernadette, if she would like to unmute and ask it. All right, if Bernadette can't unmute, I can just read it for you. I believe she's asking, is it worthwhile testing the tenderness in traditional fibromyalgia trigger points that you were previously trained about?
Oh, yes. The famous tender points. Short answer is no, not really. So those tender points were developed originally by the American College of Rheumatology guideline group, basically as a way of standardizing your patient population to make sure that you're not confusing when you're doing research on fibromyalgia, you're not inadvertently treating polymyalgia rheumatica or rheumatoid arthritis. So they selected a bunch of points that were joint lines and muscle bellies and tendinous insertions, just to get a sense of this being a diffuse pain that's not a specific rheumatologic structure. But what we realized, and the authors of the guideline realized over time, if you see a fibromyalgia patient on a good day, they will have 0 tender points. And if you see them on a bad day in the middle of a flare, they'll have 118 tender points. So it's really more a question of, do they have widespread pain? And is it not just joints, and it's not just their joints that are red and hot and swollen. It's not just muscle bellies that are tender. It's, so yeah, we have thrown out the tender points. Anything else in the chat?
Yeah, now I'm checking it and it seems like that should be it now.
Yeah, I see somebody's made a point there about MAID and fibromyalgia. There are others on this call who are more expert on this than I am. But absolutely it is, I have a couple of patients who have been approved for MAID based on a diagnosis of fibromyalgia. So yeah, and it is a big concern for me to make sure that they've got access to the right treatment and they're not choosing MAID because they don't know that there are other things out there. So part of my job when I see a patient who's applying for MAID is to make sure that they know what the options are and they're making an informed choice. Don't see anything else in the chat. Last call for anyone to jump in with questions. Otherwise, most of you know where to find me, but if you don't know where to find me, laurie.montgomery@ahs.ca. If questions occur to you later that wake you up in the middle of the night, send me an email. Happy to chat. Find me on e-advice on Netcare or give us a call at the Pain Center.